Hi, everyone. I wanted to thank you so much for coming out and participating today. Today we'll be discussing GI abstracts that were presented at ASCO 2021. I want to start off by introducing the wonderful panel we have with us today. So as moderator, we have Dr. Kevin Nuff, who is the Chief of Hematology and Oncology at Highland Hospital and also an Assistant Professor of Medicine at UCSF. We have Dr. Mark Lewis, who will be joining us in hopefully just a minute, and he's the Director of GI Oncology at Intermountain Health. And we also have Dr. Mohamed Salem, who is a GI oncologist at Levine Cancer Institute. So thank you so much to our panel for joining us. Given that Dr. Lewis is running a little bit late, I think we will start with the third abstract on the list for today. And with that, I will hand it over to Dr. Nuff. Thanks.
Hi, thank you all for attending. Dr. Salem, this was a very interesting abstract. We're eager to hear your take on it. Abstract 4002, Nivo chemo versus chemo in advanced GE junction cancer. It's already been getting a lot of press on social media. Can you tell us a little bit about this study and the abstract?
Yeah, sure. So thank you, Gala, first of all, for having us. It's a pleasure and honor to be here with you. And thank you, Dr. Nuff. And thank you for all the audience for taking the time to be with us today. I'm actually very excited to do this, especially with Dr. Lewis, who I just said he's a celebrity on Twitter, and I'm very happy to be with him tonight. So, Dr. Nuff, you are right. I mean, this abstract is, I think, is very important because for many years we actually failed to improve the outcome for patients with metastatic, either gastric, gastroesophageal, or esophageal cancer. And until this study, actually, we really, for the last few years, we didn't have much improvement. So this study was designed to ask the question whether adding chemotherapy and immunotherapy together will result in better outcome. So this was, as you mentioned, a phase 3 trial for in the first line setting for patients with treatment naive metastatic gastric cancer or GE junction or esophageal cancer. And patients were randomized to either receive chemotherapy or chemotherapy plus Nivo. There actually was a third arm that was doublet immunotherapy, like Nivo plus Evi, but that arm was closed because of toxicity concern. The primary endpoint for the study was overall survival and progression-free survival for patients whose tumor more than or equal to combined positive score of 5. However, the study also were looking at as a second endpoint for all comers, so regardless of the score, and for score more than 1%. The initial presentation was actually done in ESMO in 2020. And the study was positive, and this was expanded outcome. As you see here on the left side, the overall survival for the entire group was median 13.8 months in the Nivo plus chemo arm versus 11.6 months in the chemo alone arm, with a hazard ratio of 0.80 and highly significant p-value. You can also see on the right side, progression-free survival was also positive with hazard ratio of 0.77 as well. I would like to note to the actual manuscript just got published, I think, a day or two ago in Lancet, and the Nivo is already approved now here in US in this setting.
And the chemo backbone was Zelox or Folfox, is that right?
Yeah, so the chemo backbone was Zelox or Folfox, physician choice, and this is considered as a very much a standard of care in US and abroad.
Sure. So this is something that people might start using right away in clinic. Any problems with prescribing this therapy apart from the usual toxicities of nivolumab?
I mean, I think it's been practice changing. And again, apologies for joining the panel slightly late. Among things I've learned this ASCO, I should be blocking my clinic during the conference because the needs of the patient always come first. But thank you for letting me participate this evening. I think this was immediately, practice changing. Really, the moment the FDA granted this approval, and it's been a remarkable paradigm shift we've seen happening, certainly in the last couple of years in gastroesophageal cancers. Among other things, I don't think I'll ever give epirubicin ever again. I think it was always a toxic passenger along with platinum and fluoropyrimidine therapy. In answer to your question, I haven't particularly seen any new worrisome safety signals here. Every GI oncologist uses a platinum fluoropyrimidine backbone all the time, and adding nivolumab on top of that so far doesn't seem to have caused undue toxicity. I'm always careful not to say manageable toxicity because management is in the eye of the patient. But no, I think this is really just a remarkable shift. Frankly, I think there are some patients who are sort of caught here in the tide of progress who are now, say, on second line ramucirumab paclitaxel and are wondering how to get nivolumab. You go back in time, and of course we don't know that, and you definitely be going off label to do so. Regardless, I think this is amazing. I think Checkmate 649 at this conference, and as a slight tangent, 648, which brought Nivo-Ipi to the forefront for first-line esophageal squamous cell carcinoma. We're in a new era for gastroesophageal malignancies. And I think, and we might delve into this, but I think the real question to be answered in this particular protocol is how much does PD-L1 expression matter? I don't know about you guys. On the one hand, we're in the era of histology agnosticism. On the other hand, I sort of feel like for every cancer and even every subtype of every cancer, it feels like there's a different PD-L1 cutoff to know or memorize. And I think a lot of people were surprised, frankly, that the FDA granted approval here, not contingent on PD-L1 expression. So this is essentially a trial that enabled administration to all comers. A lot of people feel like a cutoff of 5 is a marker of enhanced sensitivity to Nivo. Some people put it at 10. It kind of reminds me of when the FDA granted a histology agnostic approval to Pembro on the basis of tumor mutational burden. Like, you can always argue an ordinal cutoff to a continuous variable. I think what's shocking here is there is no cutoff at all. You can give this to everybody. But I think the subset analyses for 5% and up and certainly 10% up are really compelling. And I don't know if you guys feel like that would change your practice. We don't want to deprive someone of effective therapy, but I also think it's important that we couch expectations to patients. I personally would wonder if someone that has absolutely no PD-L1 expression, are they going to get as much bang for their buck as someone that has a strong expression profile?
Right. Well, I've seen some patients have pretty bad toxicities from Nivo, so I'm always cautious. I treat lung as well, being a generalist, and so we know the higher the PD-1, the more probability they'll have of having a good response, and then also smoking seems to be a big factor. So it's not totally predictable; it's a little bit random, but those factors increase our pretest probability of seeing a benefit in lung, including the patients who do fine with PD-1 inhibitor by themselves or have durable remissions, which is, this survival curve is impressive that some of these patients are going to have durable remissions. So I don't think the generalists will have any problem with this because they're used to prescribing PD-1 inhibitors in melanoma and lung.
Yes. It's funny you would say that, Kevin. I was realizing this ASCO, it's exactly a decade since I gave my first immunotherapy, and that was ipilimumab in melanoma when I was a fellow, and it was terrifying.
Yes.
Because I had read all the side effect profiles. I think I literally called the patient every day to ask them about whether they were having stigmata of panhypopituitarism, probably to the point that I incepted that in their head. But I guess what I'm getting at here is I've often thought of Nivo as sort of the kindler, gentler IO, but you're right, it's not without its problems. And again, I think that's why in any risk-benefit analysis in the area of shared decision-making, I just think it's really important to be honest with patients. This is a very novel combination, at least in this specific indication, and we're going to learn as we go. And I agree with you wholeheartedly that nivolumab is nothing to sniff at. It can certainly cause pretty drastic problems. I will say I think maybe a upside here is those problems I think would be extremely distinct from the toxicity profile of salliplatin and fluoropyrimidine. So
right.
The medon's going to know.
Right.
But yeah, this is pretty remarkable stuff. I tried to
much
sober
better
myself.
Tolerated than IPI.
Yeah.
Yeah,
exactly.
Right.
And it was interesting also to see, and again, I'm slightly changing the subject, but in 648, how much exactly is ipilimumab adding to nivolumab? It does seem to be the nivolumab that's doing the heavy lifting. And again, squames are a different animal, but this, what I find sobering here, honestly, is yes, this is a great step forward, but just look at that survival curve. I mean, these people are still, they're still dying of this disease, and we've certainly changed the game and the sequence of treatment, and the long tails of these curves are extremely appealing. But the problem is the descent, happens before you get to the long tail. So this is a call to action to do better.
Right. So Dr. Lewis, what do you think of the first abstract, which I think was very anticipated?
Yes.
Very
Let me, and again, sorry you guys had to go out of order as I finished in clinic. So Keynote 177, hotly anticipated might be an understatement. Yeah. This is the promise of a chemo-free approach to metastatic colorectal cancer, as was stated in the editorial that accompanied it when it was first published in the New England Journal. So what we have here is a clarification of overall survival, whereas previously we had progression-free survival data quite famously. And again, this was practice changing arguably when it was first released. So let's delve into this a little bit. So what we're looking at here, rather than PFS, is OS. And as a reminder, there's kind of a lot happening in this study. So this is a pre-selected metastatic colorectal cancer population of people who you would expect to have response to immunotherapy. So they're either MSI high, or the surrogate for that, they're defective in mismatch repair. So again, this is not all comers by any means. And what this allowed was upfront pembrolizumab versus dealer's choice chemotherapy. And I have all the regimens listed here. I think it's all the standard regimens that we would use either here in the US or even internationally. It's your FOLFOXs and your FOLFIRIs plus or minus biologics. It makes complete sense. And then what we're looking at here, of course, is you've got PFS on the left, and you've got OS now on the right. And again, I believe, if I remember correctly, these were co-primary endpoints. What I find really interesting about this study, and we can talk about the meaning of it, is I think in the spirit of equipoise and ethical research practice, it permitted crossover. And I think that was the right thing to do, but I think we can talk, and I think this was a lot of the discussion at ASCO, about whether that has confounded survival benefit, as you might expect it to. The other thing that strikes me about these curves, and I don't know about you guys, is the fact that they cross. And what I really find a little worrisome is the initial descent. So especially if you cast your eye to your left, the initial descent of the survival curve, particularly in PFS, but also now in OS, of the pembro-only arm. To me, that is identifying a subset of patients for whom this is not the correct first choice. And again, I try not to make this too much of an abstraction. I try to imagine, well, who is this person in my clinic? What are they going to look like? And the way I've been conceiving of this, and you may feel differently, is a patient who presents with metastatic colorectal cancer and, say, a heavy burden of liver metastasis, and they are at risk to go into visceral crisis unless you get a rapid cytoreduction. And I suspect that explains that initial fairly precipitous drop off. And when this came out in New England Journal, and now seeing the OS curve as well, that gives me some pause. And it makes me think that you have to still exercise clinical judgment and gestalt, as of course we always will, and realize that perhaps not every patient with MSI high, mismatch repair defective colorectal cancer is actually appropriate for pembro upfront. And I think it's just going to, again, take a little bit of judgment and time to discern who are the people that drop off immediately. So
I'm wondering if
not at length, but those
the way to interpret that, though, is that some patients should get cytotoxic chemo and Avastin and pembro up front because it takes time for the pembro to kick in. You know, we always see that in other studies. There's a separation of survival curves because it takes 2 months for immunotherapy to work, and the patient who has a heavy disease burden, maybe they
precisely. That's exactly what, in fact, I think the median time of response in pembro was almost exactly 2 months here. So I completely agree with you, Kevin. And others online said, well, let's not throw out the baby with the bathwater. What if we maximize or optimize exposure to upfront cytotoxics and then pivot, which is, I think, exactly what you're saying. And I will say, I don't know if there's a drug in my practice as a GI oncologist that has weighed more on my conscience than oxaliplatin. And I think we've learned in the last, gosh, is that 3 years now, 4 years? Whenever IDEA was presented at plenary, I think we've learned that platinum is nothing to play with, and cumulative exposure matters. And 6 months of consecutive platinum exposure, whether Capox or Folfox, that's very likely basically half and half chance of giving you a grade 2, grade 3 neuropathy.
Right.
And so I think what this is hinting at is, as you're saying, it doesn't mean we have to jettison chemo altogether, although this notion of a chemo-free approach is very, very seductive. It may tell us that we just have to give less of agents that have cumulative neurotoxicity, and then we have the luxury, if you will, of pivoting. That's the way I would take away.
Dr. Salem, how do you think about this?
I totally agree with Mark. I think, one, this is like amazing study, but two, there is a lot to learn here, because I totally agree. Those are people you expect they should respond to immune therapy, and yet they're progressing very quickly. Also, you see the this progression rate is higher than what you expect initially. So I do agree. I think clinical judgment, tumor burden will matter. But also when you look at MSI high, we start to learn that MSI high is not the same. It actually depends on which gene is, and also how much tumor burden is there too. So I don't think MSI high is the sole answer here. I think there is a lot of other factor that will also play here. But I have to tell you, I mean, we never saw, and I would love to hear Mark's opinion too, we never saw this kind of PFS and OS in colorectal cancer. This is something new, and as you say, like it's a chemo-free. So I think it's also a very good opportunity. One question I think was raised also earlier today in ASCO, that what about doublet immune therapy? Should we start to add like CTLA-4? I'm not sure. I think I'm hesitant about that, because also that carry, as you guys were talking earlier about Nivo, this also doesn't come without toxicity. So you always have to wait how much toxicity by adding more drugs.
I completely agree. I personally didn't see, and maybe you disagree, I didn't see any new safety signals here. And again, I tend to conceive of Pembro as sort of being analogous to Nivo and its safety profile, and I think IPI is a little bit more toxic, or the anti-CTLA-4s are. Right. And again, I want to stress again the amount of crossover that happened here. So it was, I think, 36% on study crossover, and then a further 24%, if I'm not mistaken, had off study IO receipt in the folks that progressed on chemo. So I mean, that's a full 60% of the chemo cohort that one way or another got immunotherapy. And I really think that's the most likely explanation for the OS. And I know you can't, retrofit statistical analysis, and I know they didn't hit their pre-specified endpoint. But I think crossover is the main explanation. I think we would see a wider gap in survival, but I also commend them, because I think crossover was the right way to design it.
Right. But for those patients who get Pembro, they have a very high quality of life, a very impressive overall survival. This is
great point, Ken. And the quality of life part really cannot be emphasized. I think the two metrics that really matter, and we've said this at ASCO for years, OS and quality of life.
Yeah. No, this is fascinating, and this is something that we wouldn't have anticipated 20 years ago, that we could have some sort of breakthrough in colon cancer like this. And then the last abstract, in lung cancer, you've been checking for all sorts of activation mutations and targeted therapies, and now we're starting to see this in GI cancers. So it's become very interesting there as well. Obviously, with upper GI cancers, which are HER2, but now we have data about HER2 in lower GI cancers.
It's so funny. So in my practice, we subspecialize, and so through the wall for me is my breast cancer colleague, and I have told her that I have never curbsided her more than with HER2 positive disease. And generally what happens is the breast cancer docs lead the way. I think as of this weekend, they have 4 different CDK4/6 inhibitors, so they're increasingly spoiled for choice. But what's happening, which is wonderful, a rising tide lifts all boats, is we're learning the lessons of HER2-directed therapy in breast, and we're applying them to other diseases. And as you said, Kevin, now we've even gone from upper GI, sort of the toga lessons of gastroesophageal cancer. Now we're doing HER2-positive colorectal cancer. Now, I'll stress, we're kind of making every cancer a rare cancer. This is a small subset of metastatic colorectal cancer, but it's always been a particularly troublesome one because the biology has seemed different in some ways that have maybe abrogated effect of traditional chemo. I know Dr. Raghav, who's one of the co-authors here, I know he was very interested in pitting dual anti-HER2 antibody therapy and pertuzumab, trastuzumab against irinotecan and cetuximab in a SWOG trial that I believe is still maturing. Regardless, this is trastuzumab deruxtecan. So this is a really interesting, I think, antibody drug conjugate. So again, what's happening here just conceptually is the trastuzumab is binding to the HER2 receptor and it's delivering a payload of what is essentially irinotecan. It's a topoisomerase inhibitor. And I think this is such a compelling approach. Now, things that are biologically plausible don't always bear fruit. That's why we do these studies. So what we're looking at here is the PFS and overall survival of DESTINY. And DESTINY is an umbrella protocol for all the studies of this agent in various tumor types. So this is DESTINY CRC01, and I think there's vastly more breast protocols. But I actually thought this was really fascinating. Probably what we should be calling out here on these curves, PFS and OS, is the importance of the strength of HER2 positivity. So if you look at the bottom and even the colored lines on the survival curves, it really is a case where you need to be married basically to your histopathologist and really take what they have to say seriously. So the degree of HER2 expression here, I actually don't know if I've ever seen, at least in GI-onc, it matter this much. So you can see that the extremely strong expressors, so the HER2 IHC 3+, or the 2+ IHC, the positive in ISH, those are the ones that far and away got the most benefit, whether you're looking at PFS or OS. So that was one takeaway for me.
Can I ask you though, I mean, in clinic, that's sort of our limit for when we're going to get HER2 therapy.
Right, exactly.
Experience, right, is HER2 plus.
It's very reasonable, and again, I think in GI we often revert to kind of the toga criteria, and I think you're right. I think this very closely mirrors those. I was just pretty struck, and you're right, Kevin. It's just a good marriage also with conventional practice by just how much it matters here.
Is Dr. Salem, is that going to be a limiting step for you if you want to use this therapy to have 3+ only, or?
I don't think so, but I just want to take a step back to the bigger picture. I think the theme here that appears that we're not seeing colorectal cancer as one disease now. We're just seeing like subgroup, small subgroup, PRAF and MSI high and HER2 now. And you can see this strike result when you target that small subgroup, but with like the right target, so the curve goes up. This just get me to think, okay, I mean, things are advancing very rapidly, and I think there is a lot of room for education for all of us here, like how to test for, let's say, PD-L1, which one is the right one, combined score, like PD-L1 expression. The same thing for HER2, how you characterize that. And I agree with Mark. I think there is a lot of room now for us to partner with our pathologists and try to have a better understanding, but also try to get this test done early on. You don't want to wait too long.
Agreed. It's funny, our breast cancer, colleagues, they would never treat a patient without knowing ER, PR, and HER2, right? And it's almost like we now have this practically requisite set of things that we need to know. I mean, starting at the very top with mismatch repair, but arguably also TMB. I think you need to know, extended RAS. Now we need to know HER2. And you're right. One of the things I love about our field is it's so inherently multidisciplinary. It's very, very easy to be sort of structurally firewalled away from your pathologist. But I actually don't know if it's ever mattered more that we have a dialogue with them. The one other thing I wanted to say here is, this efficacy data is really pretty compelling.
Yeah.
I'll point out, I think the response rate in the really strongly expressing cohort was just under 50%, I think 45. Disease control rate was north of 80%, which is really impressive. The one thing that came up a lot, especially in the online discussion, was this concern about interstitial lung disease. Just under 10% of patients developed it. And some of the back and forth, I don't know how much you guys delved into this, was, how do we know who's going to get it? Is it a marker of cumulative exposure? Is it potentially even a sequela of prior exposure to immunotherapy? I don't think we know. I will say, anytime I'm using a new drug, I am, like I mentioned earlier about ipilimumab, I am particularly attuned to what is the thing I can't miss in terms of toxicity. And I think docs, GI oncologists are going to have to get comfortable and have a low threshold for diagnosing ILD. There are some pretty compelling anecdotes already that patients can present with at first pretty minimal dyspnea and cough, and it can develop into a nasty, nasty interstitial process, almost a la COVID, quite quickly.
Right.
So I think that's the one safety signal I found here that I think needs to be amplified.
Is that ILD reversible? Do you give steroids for it?
It does, yeah. So there's a whole protocol for it, and it does appear to be largely reversible. I just think, as with almost all ILD, I think the sooner you catch it, the better.
Right.
And it's like you said earlier with IO. IO is not completely non-toxic, and it has toxicity profile different than traditional chemo, and the same thing here.
So with GI cancers, are you two getting next generation sequencing on all patients with metastatic disease, or when do you decide you're going to look for these rare markers like HER2?
I'm close, if I'm honest, to that. The main thing holding me back, if I'm being completely candid, is reimbursement.
Yep.
I would argue there's actually certain cancers, though, and I think biliary tract cancer is the example par excellence, where if you're not doing it, I think you're underserving your patient. I think with colorectal cancer, we probably have a little bit more tissue to work with.
Right.
And so that does allow you a little bit more latitude with the testing you want to do. But frankly, NGS, it's not perfect, but it does allow you to do a lot with a little.
Yeah. Dr. Salem, you feel the same, or?
Yeah, I think it varies. The field is moving now to NGS or even whole exome. But as we alluded earlier, there are few certain markers that you must have. You can't just treat patient without knowing the basics one. And I think that's one of them. I just want to circle back to that ILD point, because I think it's very important. All of us now using more drugs and with different side effect profiles. So I totally agree. Not just the physicians, the nurses, and the infusion center also should have low threshold for alerting us for certain toxicity. And obviously ILD is very important, especially in the COVID-19 era now that everyone also have those kind of symptoms.
And Dr. Salem, I'll just pivot off that. I know we need to close here shortly, but I think in the era of immunotherapy, I've really tried. In fact, we've made an institutional effort to educate our patients too, that some side effects are not to be ignored. And what was happening in the early days of IO is people would go to the ER with diarrhea, and sometimes and this is absolutely no discredit to the ER docs. It was so novel, they would get sent home on anti-motility agents. And in fact, it was the advent of a raging colitis that needed steroids or potentially even anti-TNF. So I think here too, telling the patient, listen, there's this novel agent. Most of the time, everything's fine. Just under 10% of folks, there's this pretty serious lung problem. You got to tell us and tell everybody if you're developing, say, dyspnea. So I think you're right. When we bring new drugs into the field, it's wonderful. But all of us actually need to learn about toxicity. And I think educating the patients is super critical.
Right. Are you preparing written handouts for them, or how do you actually do that?
Well, with IO, we actually have a card that because of course IO is now nearly histology agnostic. So my colleagues and I'll give credit actually. What my GU lead here, he made a sort of crusade that he was going to make these cards, and it's almost like something they carry in their wallet. And then it's great because when they go to the ER, without seeming condescending to the whoever's working them up, just hand this card and boom, 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 it explains immune-related adverse events. So I think that's the era we're in now.
We need to get those cards here. And okay.
Try to ship you some, Kevin.
Thank you. Well, thank you guys so much. This has been fascinating, and these were really among the more interesting abstracts at ASCO this year. It's great to see some progress in GI cancers where we've had obstacles before. So thank you, Dr. Salem and Dr. Lewis, for participating.
Great.
Yep, thank you so much. From LARVOL, we really want to say thank you to our panel, Dr. Nuff, Dr. Salem, and Dr. Lewis. I mean, I learned a lot. I'm sure our audience would say the same thing. And to our audience, I want to let you know that there will be a replay of this available on our YouTube channel, so you can check that out to make sure you caught up on all the insights that were presented today. So with that, I think we'll close out. Thank you so much.
Really enjoyed it. Thank you so much, guys. Take care.
Bye.
Thanks, Mark.